This is about the class 3 for the UG students. The first slide I kept to show them the subsequent postgraduate entrance examination might be in the form of next, where they will be having both theory and practical examination for the final year. The theory part being replaced by the MCQ format of examination, which include medicine, gynec. Like there will be MCQ examination, the theory will be replaced. Practical will be the same. After that, they will be given pass or fail. They can enter the internship. At the end of the internship, there will be some phase 2 examination. That is the next phase 2, where they will be having just a pass or fail will be given to them, but the PG allocation will be based on the net score they got at in next one theory, that MCQ exam. So this is just uh, one slide I kept it to give them an idea about this next. So what is the disease that we are going to see today? This is so common in foreign countries. Around 1 in 5 men after the age of 65, almost 2 out of 5 after the age of 75 being affected with this disease. And it is more common in United States. 1 out of 7 adult population might be having this disease, which is estimated in the upcoming future decades. So what is that disease? That is the chronic kidney disease we are going to see as an overview for the UG students. So what is the CKD? Chronic kidney disease. The definition as per the KDIGO, if we see, this is the structural or functional abnormality of the kidney which persists for more than 3 months and which should have implications for health. What are the functional abnormal parameters? For the time being, the UG students have to remember it is eGFR less than 60 that brings into the functional abnormality. This we can leave apart for time. So how we are going to classify this CKD? The classification is called the CGA. The classification system is called the CGA classification. C is the cause, G is GFR, A is albuminuria. So what is this first one? C, cause of the CKD. This looking little bit complicated. We will make it simple. So as we see the structure of the kidney, each component might be getting affected, which leads to CKD. It might be glomerular cause, it might be the tubular cause, it might be the vascular cause, or it might be the interstitial cause. So that is the structural classification. Similar to that, the CKD causes, various books have given the etiologies accordingly. Diabetes is the most common etiology for chronic kidney disease. So diabetic, they themselves gave it as separate classification. Other than that, non-diabetic, it can be glomerular cause, tubulo-interstitial cause, vascular cause, cystic, some kind of cyst formation can occur, which result in also CKD, that is ADPKD. So this is the cross classification. It can be glomerular, tubular, interstitial, or the vascular component causes of CKD. Diabetes comes into the glomerular cause. Since it is most common etiology of CKD, it is being given as a separate classification. So this is all about C in short. Regarding the what are the disease, you leave apart, just understand how they are classifying. So this is what Harrison has given. What is the most common cause of these CKDs overall? Diabetes, hypertension, chronic glomerulonephritis, ADPKD, tubular interstitial disease. How common it is? It is 1 in 1000 general population. So most common cause of CKD is diabetes. Second most common, hypertension. There is some confusion between chronic glomerulonephritis and hypertension. So second most common might be chronic glomerulonephritis followed by hypertension as given in some textbooks. So I have kept this slide to show how important is diabetes in causing the CKD. So out of 1 in 3 adults with diabetes and 1 in 5 adults with blood pressure have CKD. So that common it is. So next, coming to the G component. First we have seen the C component cause, now GFR. So again, this table is looking a little bit complicated for the UG students. We will make it simple. So this is the staging. Stage 3A, 3B, the eGFR is 30 to 60. For stage 4, it is 15 to 30. For stage 5, eGFR less than 50. This is the stage at which the patient might be dialysis requiring. Then what is stage 1 and 2? That we will discuss in the subsequent slide. So CKD starts from eGFR of less than 60. So that's why in the first slide I have told eGFR of less than 60 defines CKD. Then to third criteria A. C is done, G is done. Now we came to the albuminuria criteria. It is as simple as that. Albuminuria A1 is less than 30 mg per day. A2 stage is 30 to 300 mg per day. A3 is more than 300 mg per day. The ACR albumin creatinine ratio, 24-hour albumin excretion rate that I have discussed in the class 2. But overall, the 24-hour urinary albumin excretion is less than 30 mg. So just forget this ACR and all. 24-hour, the patient or someone adult patient can excrete only up to 30 mg of albumin. So if it is less than 30 mg, which is the normal, that is A1. If it is 30 to 300, that is A2. If it is more than 300, that is A3. So combining all together, CAG, remove the C, the overall classification, this table is very important. So as you see here, eGFR of 60 to 90 more than 8. Normal GFR is 120. So if we see here, this is given in green. That means there's a very less risk of progression to a complication or development of the end stage renal disease. This color is being given. The color code indicates what is the risk the patient might develop some kind of kidney failure or some kind of complication related to the kidney failure. So the another component comes A1, A2 and A3. Here it is look at the unit milligram by gram, milligram by millimole. We will make it simple. So it is less than 30 milligram, 30 to 300 milligram, more than 300 milligram. Look at the color. If the albuminuria is not there, eGFR of more than 60, it is almost normal. No need to say it as CKD. So this part will be a little bit confusing. So that's why I have made this overall table, which will be easy to explain. So here it is green. Suppose if the patient is having proteinuria, even a GFR of 90 might have some risk. A3, yes, there is some risk if there is a more proteinuria. Proteinuria is toxic to the kidney. That might lead to the development of the CKD in future. So that is why this table is given. Actual definition of CKD starts from here. Considering albuminuria, the table is extended up also. So for the time being, UG students have to be clear with this table. What are the components of this table? Why the color code being given? So the classification we have seen, how it is classified as per the cause, as per the GFR, as per the albuminuria. One question, is the end-stage renal disease is same as CKD? The answer is no. CKD is not equal to end-stage renal disease. When to say as end-stage renal disease? End-stage renal disease is a condition when the toxic material got accumulated to the level without renal replacement therapy, patient might not able to survive or cope up with that. The renal function is totally lost. So that occurs usually at the stage 5, eGFR of less than 15. So ESRD means the toxic material got accumulated. The patient needs some form of renal replacement therapy. So what are the risk factor for this CKD? It is simple. Whichever causes CKD is also risk factor. Less water intake, cardiovascular metabolic syndrome. Just for theory, you can go through this. So what are the, we have seen what is CKD, what is classification of CKD, how we have divided it according to the cause, albuminuria and GFR. Now we are going to see what are the manifestation can occur because of CKD. This slide I have used it during the anatomy physiology part. Since kidney is having endocrine, excretory and homeostatic function, once the patient kidney function gets lost, all this gets affected. So basically, it excretes nitrogenous waste product. It gets accumulated. It maintains the blood pressure. So the patient develops hypertension. It maintains the electrolyte balance, acid-base balance, osmolarity regulation. All this leads to dyselectrolemia, metabolic acidosis, hyperosmolarity. It forms vitamin D. So vitamin D won't be formed. There will be CKD, mineral bone disease. It forms CPO. So the patient develops anemia. So these are all the complications. What are the toxic material which gets accumulated? That can be classified according to the small molecular weight, middle molecular weight, and the protein-bound toxin. So see where urea creatinine is one of the component of the uremic toxin. There are so many uremic toxin. So for UG level, it is looking little bit uh, like heavy with respect to. So we will make it simple. So there are toxic material which gets accumulated in the body when the patient develops CKD. So there are so many toxic material. What this toxic material causes? This causes various clinical manifestation. We will see one by one. So we will see it by a simple mnemonic A, B, C, D, E, F, G. One of the few important questions which might be asked. What are the things the patient might develop? To simplify it only, I have kept there are so many things the patient might develop. At least you have to answer these things. First is anemia. Why anemia? Because of low erythropoietin. Other than that, anemia, the patient have iron deficiency, decreased iron absorption, chronic inflammatory state. These are all the things because of which patient might develop anemia. Abnormal blood clotting can occur because of uremia, which is called uremic bleeding. Second is the bone abnormality. B for bone abnormality. What happens whenever the kidney starts reducing its function? There will be accumulation of the phosphate. Also vitamin D deficiency, which result in low calcium. The high phosphorus causes FGF secretion, fibroblast growth factor 23 secretion. This affects the bone also, and there will be hyperparathyroidism. This stimulates IPTH. IPTH gets secreted because of low calcium also, high phosphorus also, and FGF23 is the most important factor which stimulates IPTH. This causes bone abnormality. So this component is very, very important. One MCQ point where this FGF23 is secreted, it is secreted from the osteocytes. Third is cardiac abnormality. What are the things the patients are more prone to because of the toxin? They are more prone for accelerated atherosclerosis, congestive cardiac failure secondary to volume overload. There might be development of uremic pericarditis. What is D? D is dermatological manifestation. Patient develops lot of itching. It's a uremic pruritus. What is E and F? E for electrolyte abnormality, F for fluid imbalance. So there will be edema, usually pitting edema, hyperkalemia. Patient comes with heart block, hyponatremia because of the water accumulation. There will be metabolic acidosis. Initially non-anion gap. As the stage proceeds further, there will be uremic toxin and further high anion gap metabolic acidosis can occur. So these are the important component. G. G is gastrointestinal manifestation. Because of the uremia, the patient develops severe gastritis. They may present with recurrent vomiting. That is called as uremic gastritis. The patient might have loss of appetite, malnutrition. They are more prone for malnutrition, inflammation, anemia syndrome, Mia syndrome. CNS manifestation. One last thing is the uremic encephalopathy. Patient might develop dementia. All sorts of neuropathy patient might develop uremic neuropathy. But one important component UG students have to remember is the uremic encephalopathy. So how we are going to diagnose it? So this is the some representational image what happens in CKD. This is a clear bean-shaped kidney. As the CKD stage progresses, it became like a this lusterless, blackish type of kidney. Not all disease, but mainly whichever disease causing CKD, usually the kidney goes for a shrunken state. What is the best test to diagnose is the ultrasound. So this is how a normal kidney appears. Well defined, bean shaped, clearly cortex and medulla is differentiated, hypoechoic, hyperechoic. Cortex is hypoechoic, medulla is hyperechoic. So what happens in CKD? The kidney gets shrunken. The normal size of the kidney is 9 to 11 centimeter. The kidney gets shrunken in CKD. Normal is almost all the CKD. The kidney gets shrunken. But there are few conditions where kidney might be normal size, like diabetes, HIV, amyloidosis. These ADPKD, these are the MCQ question where they might be asking most of the CKD kidneys are shrunken. There are few conditions where kidney might be normal or bigger size. Diabetes, HIV, autosomal dominant polycystic kidney disease, amyloidosis. These are the few conditions where kidney size might be maintained or it might be bigger in size. So what are all the most important things as a UG student they have to remember is, if a CKD case comes, what are the findings you will get in examination? Because for diagnosis I have told, we will remove this. For diagnosis we will go stepwise. Examination. First, in the examination there might be presence of anemia. Patient might have pallor. There might be spoon-shaped nail because of iron deficiency, chronic malnutrition state. There might be hyperpigmentation secondary to uremia. Presence of edema, fluid overload state, bilateral pitting pedal edema, periorbital puffiness might be there. Uremic fever, it is nothing but presence of urine smell in the lung. Basically, urine smell in the breath of the patient. It is because of the ammonia which gets formed in the lungs. There might be presence of pericardial rub. If a patient of CKD or if you get some other cardiovascular system case, definitely there will be a question how to differentiate between pleural rub and pericardial rub. So these are all the points might be present in a patient of CKD, the important points examination wise. Second, what are the things? Blood examination. Usually whatever the ABCD I have discussed, hemoglobin might be low, urea and creatinine might be high, sodium might be normal, potassium might be high, calcium phosphorus high, IPTH high. This is secondary hyperparathyroidism. What are the things you can find in urine? Is that urine is going to helpful in any way? In CKD and stage disease, is of mostly very less helpful. You can't make any diagnosis with the help of urine examination. So proteinuria might be variable as per the etiology. RBC might be present, might not be present. So for MCQ point of view, there might be presence of broadcast. Broadcast is nothing but the tubules are getting dilated. There might be formation of cast inside the tubules. Or there is the presence of isostenuria. Isostenuria is nothing but the urinary specific gravity can't be changed. The urine will be produced at a particular specific because there is no concentrating diluting capacity. Next is the USGKUB, which this is the most important investigation. The patient will be having shrunken kidney. What is the role of biopsy? In a CKD end-stage patient, the biopsy role is very minimal because kidneys is already shrunken. Whatever the biopsy, if we do the biopsy, what we will get, there will be a complete fibrosis of the kidney. There is no much clue. So that's why biopsy role is very important in AKI, but it is have no much role in CKD because it show only fibrosis. So examination, blood investigation, urine investigation, USG and biopsy. If kidney size is normal, there might be some clue regarding the primary disease. Why we have to diagnose the primary disease? Is the kidney going to recover? In stage kidney disease, very difficult to recover. It won't usually. Then why biopsy? We have to find out the primary disease so that we will know the recurrence if the patient is being planned for transplant. So this is all about CKD. We have seen what is CKD, how we are going to classify, what happens, what are the complications which can occur. So what is the role in the management? We have to stop here. Like from CKD going to ESRD, going to death, the cardiovascular disease, that part have to be stopped. That is the primary intention of the management of CKD. This we will see in the subsequent class. There are few images I have kept as a spotter. This is half and half line seen in CKD. The proximal, the distal darkest portion, proximal white portion, also called as lens line. What is E in eGFR? It's an estimated GFR. We are estimating. We are not exactly measuring. We are estimating based on the serum creatinine. Simple image: autosomal dominant polycystic kidney disease. It is studded with cyst. This is just to make a like connect and diagnose image. The patient is. This is a clue saying CKD because Arun Jaitley was suffered from CKD. He underwent transplant also. These patients are more prone for secondary hyperparathyroidism, which result in fracture. The fracture is more common in the neck of femur, humerus fracture, pelvic bone fracture. Regarding the management of this CKD, we will see in the subsequent